Improving patient safety is every caregiver's concern. While each hospital customizes its patient safety efforts and strategies to best meet the needs of the patients and communities it serves, certain practices hold promise to help just about everyone. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly with AHA Communications. In this month's Leadership Dialogue Series podcast, hosted by Dr. Joanne Conroy, CEO and President of Dartmouth Health and 2024 Board Chair of the American Hospital Association, we hear from Dr. Stephen Diaz, Chief Medical Officer at MaineGeneral Health in Augusta and an AHA board member, about how things like accountability, prioritizing teamwork, overcoming barriers, and using artificial intelligence are helping to deliver quality care that is safer than ever. Let's join them.
Thank you for joining us today for another AHA Leadership Dialogue discussion. It's great to be with you. I'm Joanne Conroy, CEO and President of Dartmouth Health and the current Chair of the American Hospital Association Board of Trustees. You can tell that I have some laryngitis, but I am delighted that I don't have to do a lot of the talking because I'm going to be joined by Dr. Steve Diaz, who's Chief Medical Officer of MaineGeneral Health. MaineGeneral Health is a comprehensive nonprofit health system located in Augusta, Maine. And in addition to serving as Chief Medical Officer, Steve is an emergency medicine physician by training and is deeply involved in many of MaineGeneral's healthcare quality and safety initiatives. Earlier this month, the AHA released a new report showing that hospital and health system performance on key patient safety and quality measures was better in the first quarter of 2024 than it was before the COVID-19 pandemic, and that hospitals made these improvements while caring for patients with more significant healthcare needs. Last year, the AHA launched a national initiative to reaffirm our leadership in commitment to patient safety. AHA's Patient Safety Initiative is guided by a clinical advisory panel and a strategic advisory group. They focus on reducing patient harms, increasing health equity, and improving public trust. But before we jump into our discussion and my questions, Steve, our audience really wants to know about our speakers. So can you share some information about your background and how you got to MaineGeneral and how that's affected your approach to patient safety?
Thank you, Joanne. I'm glad to join you today. I started in healthcare prior to medical school. I was in EMS, worked in Sacramento ambulance, and decided I would take the plunge going to medical school. And growing up in California, I decided to have an East Coast experience. I went to Cornell New York Hospital, thinking after that I'd go back to California. I was somewhat wayward, took a year off and taught there, and then decided to do family medicine training to start with, and would go to a rural area again to grow up and figure out what I wanted to do for my life. So I said that I would go to Maine for 3 years, 31 years ago. Finished my training and then went into emergency medicine and grandfathered into that a long time ago. And then became involved in disaster, EMS, and emergency medicine on my way to becoming an administrator for MaineGeneral. It's interesting. I think prior to medical school, having that EMS experience was key. We work in teams. We've always thought we worked in teams. We really strive to work in teams. And I would say the thing that I focused on at MaineGeneral is flattening the hierarchy and moving things so that we're all taking care of patients in a coordinated fashion rather than everybody having a different care plan, if you will.
So, Steve, you and I share an affection for the state of Maine. My family grew up in rural Maine. But why patient safety? Because emergency medicine, you can take many paths after training in that specialty. But why was safety such a passion for you?
Safety is such a passion because in emergency medicine, the times that we get involved in the high acuity situations is not as common as taking care of ambulatory sensitive conditions or even intermediate medical conditions. Because of that, when we do critical care in emergency medicine, it's not the most common thing we do, whether it's central lines intubations, using vasoactive drugs or other things that are very aggressive, you have to be sure that the whole team is ready for that. Today, of course, we all have care bundles and team practice in STEMI care, sepsis, stroke, and trauma, all the time-sensitive conditions, but that was not the way it was 30 years ago. One of the roles I had early in my career here in Maine was I was the medical director for Maine Emergency Medical Services, so the state medical director, and we worked to have state protocols for STEMI care, for ER to cath lab. We worked to have state protocols for stroke care. Prior to my time there, we had state protocols for trauma care, and now sepsis care, again, having state protocols or state initiatives that it starts with EMS will hopefully change that curve as well. So it appealed to me because you have to plan for it. You have to have teamwork. Be critical of yourselves, both individually and as a team, in order to improve the care and the outcomes of the patients we serve. So that's why in emergency medicine it called to me.
Now, you trained in a rural area. That's got to be different than delivering emergency care in an urban area. What are the challenges that you've run into in rural Maine, where most of the hospitals are critical access hospitals, except for a handful of quaternary care facilities?
I think the biggest issue in rural emergency medicine care is you don't have the consultants at your fingertips, if you will, whether it's trauma, stroke, heart attacks, or STEMIs. You might have to be creative on how you get those patients the care they need and find your consultants. I think in many ways I was fortunate that I was a EMS medical director for Maine early on, because I met a lot of people across all the systems. And again, the goal here was to have a system of care so that no matter where you went, you'd have the same care. So let me give you an example. When I was a young ER doctor and I had somebody with a ST elevation, myocardial infarction, or a heart attack in front of me, the referral centers with cath labs who did interventional cardiology had 3 different protocols. And so I had different color folders, we all did in our ER, depending which tertiary care center they chose. And so, and heaven forbid that you pick the wrong folder color and someone changed their mind or there wasn't bed availability. Nuances were not significant, but they were nuances. And so we worked to have that really ironed out. And I think that is the same discussion you have with stroke care, although that has really been helped by other entities having some standardized protocols, but then having the consultants know who you are and where you call them. Interestingly enough, my preferred shift was the weekend overnight shifts in the ER. It just seemed to be a shift that went by quickly, lots of teamwork, no offense, less suits around, but it also made it so that I really had to know my consultants and know where I was going. And in rural emergency medicine, rural states, or rural healthcare in general, again, you have to know where you're going to go because you might not have a lot of things in-house. And that was true 30 years ago, and it's still true today, making it more important that we know our networks of care and our consultants.
So, there's a lot of conversation about AI. Is AI going to improve safety, do you think? Or is it going to jeopardize it?
It's funny when you talk about AI and or even machine language, I think of 2001 Space Odyssey, people become HAL, the computer taking over everything, or Star Trek with the little device. I don't think that's how I see AI helping us. We spend a lot of time outside of the diagnostic and patient-facing time to get people on a care plan, talking about things over and over again in order to help them. And I think that's where AI could help us. If you have somebody getting a procedure or going on chemotherapy or other complex medical conditions, informed consent to ongoing education could be a boon for AI that identifies, people with heart failure and which class they're in and what they need as education. AI could say, well, hold on. Once you're done with them in the office, you can send them this, or they'll be identified by AI to receive these education, either online, print, depending on how they learn best. And it's always available to them, and we'll check in with them. It sounds like a little bit perhaps of care management, but it's even beyond that because it'll speak to them in a way, and you can test them so they get the information the best way they get it. Right now, all those things are done by people. If it's not the physician, it's the NP or PA, or it's the nurse or the care manager, and we're all happy to do it, but none of us have that conversation once. And oncology is my favorite example of this. If you see an oncologist and you're told you have something, that usually happens in the first few minutes, and the next 15, 20 minutes, no offense, the patient and family don't hear anything else.
Yeah.
And that'll be me if I remember it. I mean, there's no way I'm going to remember anything past whatever they tell me. That just shifted my whole world. But wouldn't it be great, though, if someone had a link that was identified for them, where AI can help answer their questions and gets information back from them that's given to the care team to help create the right message for them? That'd be incredible. That would be world changing, giving people back time um, to not be burdened by the administrative.
So it's almost personalizing their treatment plan. We actually do videotape, or on your phone, our visits. So patients actually can refer to the conversation later, because you're absolutely right, Steve. After they hear that they have a diagnosis of cancer, they don't hear anything else. And all that important information is lost. Let's talk a little bit about AI in like record abstraction. Remember when we started using algorithms to oversee our ICU care? We identified that there were some early warning signs so we could anticipate when somebody might be unstable before they actually became unstable. What do you think about using AI for chart abstraction and kind of identifying things that are very difficult for our chart abstractors currently to pick up?
I think that'd be ideal. Right now, as you know, we spend a lot of administrative time either at the physician level, MPPA, coder, biller, trying to find those magic words that people are looking for in order to determine your risk stratification and thus your billing, and even quality metrics at the back end. It shouldn't be a game, right? We should be able to say, I remember early on as a young doctor when I kept saying urosepsis, I got the nasty gram saying, no, you mean UTI with sepsis. That very specific words. So AI should be able to help with that. Should be able to take the human element out of it. Let us practice and talk, and then make the crosswalks so that it gets categorized the correct way and in the correct format. To me, that's yet another easy lift. And I've seen the products. I've been demoed by some of our younger medical staff who have me as the patient and they're the doctor, and we just have a conversation and they hit a button and it can either generate a consult note, the H&P, the SOAP note, and it's better than anything we could have delivered or dictated. And so, we do think there's a way coming that'll make it more compliant and hopefully, again, get some of the red tape, some of the administrative burden out of healthcare.
Let's talk a little bit about safety and how we create community partners, because patient safety is of great interest to people in our communities. And you live in a community like mine that people come up to you in the grocery store and in the coffee shop. And safety is probably one of the number one things that our patients worry about. How do you actually engage the community so you have internal and external partners that are working on safety across the community?
I will take an example in the behavioral health addiction medicine realm. When I was a young doc here again decades ago, the construct in the community for behavioral health is very strong. And today, all of those community partners are under duress. We actually surveyed them about 2 years ago on the pediatric realm, trying to figure out how we bolster more resources for people who need help in either mental health or addiction medicine services. And I'll just say that everybody needs more help. And so we convened from that discussion a small conference that is now an ongoing symposium where we try to bring all our partners together to discuss this openly. How are we sharing patients? What's the best way to go forward? Where should we go speak to the community? Who's our audience? And so that's one small example of taking a piece of what we have to try to do more with it. It's not surprising that was spurned by the adolescent mental health crisis that's sweeping the nation, that's also linked to suicide. So that was sort of the call to arms for that. But I take that same paradigm, and that is sort of how we go out there to meet people where they live, whether it's behavioral health, CHF, COPD. There's a lot of community partners that we need to intersect with in order for the people to have the care they need, because we can't do it all alone.
Especially in rural America, we figured out that our external partners are really important in actually keeping our community healthy and keeping our community safe.
Right.
I want to thank you, Steve, and I want to apologize to our audience for having laryngitis today. But Steve did most of the talking, and I thank him for that. We appreciate you sharing your valuable expertise and insights. Thank you very much from rural Hanover, New Hampshire to rural Augusta, Maine.
Thanks for listening to Advancing Health. Please subscribe and rate us 5 stars on Apple Podcasts, Spotify, or wherever you get your podcasts.